This presentation is intended for general educational purposes only. It is not medical advice. It is intended to present you with our own opinions regarding the topics presented. It is not the intent for the presentation to be a substitute for seeking personal medical evaluation. It is commonly said that a person who treats themselves has a fool for a patient. All symptoms have a list of potential causes. Only a trained medical professional can optimally apply available tools to return you to your best possible health. It is our hope that this presentation makes you a more well-informed and better consumer of healthcare services.
Hi, my name is Dr. Sean Panzer, and I'm a gastroenterologist here in Denton, Texas. And today we're going to be talking about problems swallowing. And this is a really common problem. This is a problem that many times is related to acid reflux and can be, as we'll talk about, and can be related to a number of other medical conditions, including post-surgical problems, medication-related problems, and sometimes problems that are even related to diseases that affect the entire body. And as I've said in other videos, problems that you have elsewhere throughout your body, in other words, systemic type diseases, affect the gastrointestinal tract in many ways, and problem swallowing is no different. Now, the official term is what we call dysphagia, and that simply means difficulty swallowing. A different problem is odonophagia, where you have painful swallowing. But both of them are caused by related conditions and are included in the swallowing difficulty symptom. So what exactly is the symptom complex that goes with problem swallowing? And you can have a number of different things. You can have problems initiating your swallow. You might have problems having respiratory symptoms with swallowing. So in other words, you go to swallow liquids and you start coughing, or you start developing changes in your voice, or you might have lung problems such as what's called bronchitis, or what's called aspiration pneumonia, where you actually take material down into your lung and it blocks off segments of that. You might have a sticking sensation in the chest, and so there are a number of different ways that this can present. You might even have chest pain when you swallow, and so these are the different things you have to consider as representing an underlying problem. And there are a number of things which cause swallowing difficulty, and they range from things that are neurological on to problems with the esophagus itself, external compression, and we'll talk about all those things. Before we do that, we need to go over the normal anatomy, so I'm going to have you focus on one of these pictures right here. So when you swallow, food goes over the tongue, and then it goes down this long tube called the esophagus. Your lungs run either side, and your heart's here. Your windpipe is in front here. The food then goes into the stomach, where it mixes with acid. Muscles of the stomach grind up the food. It sits there a while, then goes into this C-shaped area called the duodenum. That area is important because you have two things emptying there. One is your pancreas, which runs right here behind your stomach. It makes a juice that you need to break down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is the liver, and it makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes down through the pancreas and out to the intestine. Your gallbladder is attached there, and it serves to store the bile until you eat, then squeezes the bile in to mix with the food. From there, it goes down about 23 feet of small bowel, during which time nutrients are brought into the body, water and waste is left behind. That comes out in the right lower part of the belly in an area called the cecum. That area is important because you have your appendix there. And as the water and waste goes up the right colon, across the middle, down the left colon, and then makes this S-shaped turn to where it comes out, the water is removed, and the stool becomes firm, okay? So when you have swallowing difficulty, we're obviously interested in what's going on up here in the, kind of in the mouth and the mouth area, this area which is called the oropharynx, and obviously the esophagus. Plus, you also have to be thinking about what's happening around the esophagus. So the esophagus courses down the middle of the chest. Your heart sits right in front of the right in front of the esophagus. The aorta, the big vessel that comes out of your heart that feeds all the rest of the body, sends off blood vessels to the rest of the body, runs alongside that. Your spine is right here behind the esophagus. You have all kinds of lymph tissue, part of your immune system, what are called lymph nodes, that are next to the esophagus. You have vascular structures such as a subclavian artery, which comes across the esophagus, and that can have an impact on swallowing as well. So you have the structures in the chest. Then you have the anatomy of the esophagus itself, and the top part, the top third of your esophagus, is what's called striated muscle. And this is the striated muscle is muscle that you control. So the top third is under voluntary control. Of course, all the muscles, including your tongue, the muscles that are in the back of the throat, are also under voluntary control. And then you have the bottom 2/3 of the esophagus are what are called is made up of what's called smooth muscle, which is automatic muscle. And so once things are initiated, things occur, movements through the area are automatic. At the bottom of the esophagus, you have an important structure called the lower esophageal sphincter, which is under both neurological as well as chemical control. And so it is usually closed, and then once food approaches from above, it opens up and the food goes into the stomach, and then it's supposed to close back again. So you have a combination of nerve impulses which inhibit the esophagus and allow it to open, and then you have other ones that keep it closed. When you go back to get a little more detail on this anatomy, there are a number of muscles which impact swallowing, and swallowing is just one of those things that's automatic. You just don't really even think about it until you have a problem with it. And so you have of course your chewing, which means you have to have a good teeth structure. Obviously, if you're missing a lot of teeth and you can't chew your food up as small as you used to, then it's going to be harder to get it down. So the quality of your teeth has an impact on that. Then you have the tongue, and your tongue is important. It pushes the food around, moves it around to your teeth, and then propels it to the back part of the throat. If you're missing part of your tongue related to surgery, in particular for head and neck cancer, then that movement is restricted, and that actually can have an impact on your swallowing. And then once the food gets back here to the back part of the throat, then you have a number of muscles which work together to open the esophagus. You have what's called the upper esophageal sphincter here, which is not a distinct structure, but is actually made up by a number of muscles, the major one being what's called the cricopharyngeus. And then on top of that, you have the esophagus being opened, and then you have muscles that actually lift your windpipe and allow this little flap up here called the epiglottis to close, thus preventing food and liquid from going into the windpipe. And so once the food and liquid make it past that point, then you have this upper esophageal sphincter open, the food goes into the esophagus, and then you have what's called a process called peristalsis. Peristalsis is a smooth wave of contraction that occurs from top to bottom, and if my pen is food, then the muscles above my pen will contract, the muscles below it relax, and you just have this nice wave of propulsion down from the back part of the throat here into the stomach to move things through. So that's the anatomy of swallowing. And of course, your brain is an important part of that process. As I said a minute ago, the nerves that come from your brain into this area as well as into the esophagus are all very important parts of this. And so, like everything else in the human body, it's a very complicated system, and when everything's going well, you really don't think about it, and when things are not going well, you have to think of a number of different structures, a number of different areas that could be having an impact on what's going on. So that's the anatomy of swallowing. And what we'll do is we'll talk initially about the different modalities I brought to bear in terms of working up swallowing difficulty, and then we'll go into some different conditions that can cause problems with swallowing, and then also talk about the treatment. The main things that are going to be brought to bear when it comes to diagnosing swallowing problems that might be causing swallowing difficulty depend on the kind of symptoms that you're dealing with. So if a person comes in and they say, that they have neurological, let's say they have neurological problems such as they've had a stroke, they have Parkinson's disease, multiple sclerosis, some of the other neurological type problems, then those symptoms suggest a problem more along the lines of what we call neurogenic dysphagia, or problems related, basically swallowing problems related to impaired nerve function. And so in that situation, you're going to be relying more on the barium type studies, in other words, X-ray based studies, because what you want to see is you want to see how the swallowing is actually working. So we usually, in that situation, we'll usually do what's called a modified barium swallow, and it's a simple test, old test, in which a person goes to the hospital and or some kind of radiological facility, and they basically swallow barium, and so they'll swallow barium, they'll swallow it in different consistencies, they will swallow barium tablets, other things, and so the idea being that you're watching to see how the material is flowing out of the mouth area into the back part of the throat and then towards the esophagus. And so people who have had a stroke, for example, they have a hard time with that coordination, and so you might find that the material goes into the windpipe, and so that's going to be the main focus there. If you have more of a problem with swallowing, let's say, liquids and solids, or a problem swallowing liquids at hot temperatures or cold temperatures, that suggests more of a problem with what we call esophageal motility. So in other words, it suggests a problem with the coordination of the esophagus itself. And so again, in that kind of situation, you're probably going to be relying on barium studies like barium swallow, because we can look at that wave of contraction I was telling you about, what's called peristalsis, and we can and so we can see how things are moving through the esophagus. Another test that's done for that is what's called esophageal motility, and included in that is what we call impedance plethysmography. And in that study, you're looking, basically it's a catheter-based study. It's put through the nose and inserted in the stomach, and then it's slowly withdrawn as you're swallowing. And so it allows us to take pressure measurements of the esophagus, allows us to see how different segments are working, how the coordination is working. And so again, that's a test that helps us do that. As I said in the reflux video, the impedance plethysmography allows us to take pressure measurements of the esophagus, as well as detect things like what's called bowel reflux, where material's coming up into the esophagus, and that can cause esophageal spasm, and is something that you also may see brought to bear. Those two studies, we had esophageal manometry, which is the way we measure the pressures in the esophagus. We had that here in Denton. We don't use that so much in private practice. I think you'd see that more in an academic kind of approach, or an academic kind of a setting. And then, of course, one of the mainstays of working up this kind of problem is upper endoscopy, and that's going to come into play when a person comes in and they say that they have a feeling that there's a lump in the throat, or if a person comes in and says, I'm swallowing, when I swallow solid food, it gets stuck. And that suggests more of a problem with a structural issue. And of course, if you come in and you say you've been throwing up blood, you've been losing weight, any of those kinds of things, we're going to want to know what's going on structurally with the esophagus, and that is best diagnosed by upper endoscopy, because it also allows us an opportunity to treat things, which we'll talk about here in just a few minutes. And CT scan of the chest is important, because it allows us to look at structures around the esophagus. As we'll talk about in a minute, some of those structures can impinge on the esophagus and cause swallowing difficulty. Obviously, cancer, other structural issues will be detected by CAT scan radiography as well. And even plain X-rays can be helpful, because sometimes people can have what are called osteophytes, which are bony growths that extend from the spine. And if they extend towards the esophagus, they can actually impinge on the esophagus and cause swallowing difficulties. So something as simple as just a plain X-ray of your spine might be useful as well. And I think you probably also have to put in that discussion the empiric trial of a proton pump inhibitor. In other words, where a person listens to symptoms and says, hey, let's try this. let's try this medication and see if reflux is the issue. And some people will do that, but again, you just want to make sure that there's no structural problem, particularly esophageal cancer, because it is a devastating disorder that usually leads to death and is found at an advanced stage once you develop swallowing difficulty. So again, the most important thing is that if you have symptoms of swallowing difficulty, they should be evaluated in some way. And obviously there's overlap too. So there's some overlap. Some people who have a physical narrowing of the esophagus will have swallowing problems with liquids. And so atypical symptoms like new onset asthma, dental problems, things like that can also be part of reflux and be part of a further symptom of swallowing difficulty. So what I want to do now is talk to you about these different disorders, and obviously you can conjure up a lot of more uncommon diagnoses to think about, but we're going to kind of cover the most important ones initially. Okay, I know you can't see me very well with this, the way I have this set up, but I really want you to be able to see this anatomy here as we go through these conditions. And so what I'm going to do now is basically try to present this in a kind of a logical way, and we're going to basically start from the top, so to speak, and go down towards the stomach in terms of the different causes of swallowing difficulty, as well as what we use typically for each one of these in diagnosis, and then treatment as well. So we'll kind of catch all that as we work through these. And so as I mentioned earlier, one of the areas where you can develop difficulties in regards to swallowing regards the neuromuscular control. In other words, the nerve and muscle control of the throat and the mouth. And as I said earlier, you have to get a lot of things have to happen. You have to have your teeth have to grind the food down to get things down, and your tongue has to move in a proper direction. And so all these and then you have the neurological input. So for example, a stroke or the neurological type causes have a big impact on swallowing. And when you have a stroke, it affects your swallowing. What's happened is you've lost the neurological input, and this can come from a number of different areas in the brain, from the lowest parts of the brain all the way to the cerebral cortex. And so when a person has a stroke, then they may have an issue with the way the tongue moves, but more commonly they're going to have a problem with the way the control of the back part of your throat has been affected. And so, as I said earlier, when you swallow, the muscles in the back of the throat lift up the windpipe, close the epiglottis over top of that, the little flap that closes the windpipe off, and then opens the back part of or the top part of the esophagus, and then the food is able to move into the top part of your esophagus, which is also under voluntary control. And so, when a person has a neurological problem like a stroke, multiple sclerosis, Parkinson's disease, various kinds of dystrophies, then we are going to be using tests that allow us to tell if that's a problem. So again, a person who has this a neurological type problem will come in and they'll have problems with handling liquids. So when the liquids go back to be admitted into the esophagus, they just sort of sit here. The muscles are not coordinated right, and so those liquids can spill into the windpipe, which causes coughing right at the time of the attempted swallow. Can go farther down and affect the vocal cords, where a person might have some voice changes, and then make its way into the upper windpipe, which is going to give you what's called bronchitis, and even go down far into the lung and actually block off the airways, and that can be pneumonia. So that type of pneumonia is what we call an aspiration pneumonia, and many times that kind of pneumonia will be more on the right side. And so when a person has presents with such symptoms, they usually obviously have other kinds of symptoms to suggest it, including facial paralysis, paralysis on one side of the body or the other, changes in sensation and movement disorders, a blank face, things like that. So usually those disorders don't just affect the esophagus, or the swallowing, but also affect other neurological functions. And so for this kind of a problem, we're usually going to do what's called a modified barium swallow, where a radiologist helps us, and we basically watch to see how various consistencies of barium pass into the esophagus and then on into the esophagus itself. The treatment for this depends on the severity of the dysfunction. And so if a person has a situation where, let's say, it gets to the back of the throat and just kind of sits there but ultimately goes down, and very little or none gets into the airway, then you'll usually get some treatment through a professional known as a speech therapist. And what they'll do is they'll show you how to move your chin and how to swallow, kind of almost kind of retrain you to swallow as the nerves are healing in the affected area, or medical treatment is adjusted or initiated. And so that's going to usually be the main type of workup on that. Now, sometimes people will have surgery done in the head and neck area, which is done usually for cancers in this area. And so depending on what's done, then a person will have various forms of impairment. And so they might have a problem, let's say part of the tongue is removed. They may have problems transferring food to the back of the throat. If they have had a lot of muscles in the neck removed as lymph nodes are removed to deal with head and neck cancer, they may lose some of the muscular function. And also, if you have radiation therapy, many times that extends into the upper esophagus as well. And so you can either lose the muscle function, which affects everything here, or you might even develop a narrowing, which we can many times address doing upper endoscopy and then stretching the esophagus to eliminate that scar tissue in the back part of the throat. So that's the second thing that can happen. Then as you move down more towards the esophagus, as I said earlier, you have what's called the upper esophageal sphincter here, which is made up of numerous muscles, but in particular one that's called the cricopharyngeus. And so there's a little area of weakness between these muscles that's called Killian's triangle. And so if this upper esophageal sphincter is either too tight or it's not relaxing like it's supposed to, then as you initiate swallows over a number of years, you can get a little outpouching of the esophagus, and that's what we call a Zenker's diverticulum. And when that develops, symptoms can follow depending on what direction it's pointing in. So if it's kind of forming upwards like this, then it's not going to affect anything because it just empties immediately. If it's going towards the back here, or it is or if it's kind of drooping down a bit, then it can accumulate material, food, pill fragments, stuff like that, and that can then be regurgitated back towards the airway, and you can have symptoms not only of swallowing difficulty, but you might actually feel a fullness in the neck. And so with that condition, we will again use barium studies. We can identify those with endoscopy at times, but many times the barium study is going to show us that. And so one thing I forgot to mention, I want to go back. One thing I forgot to mention is that when a person has a stroke, if the swallowing is so impaired that there's nothing is going to the esophagus, that there's a high risk of material going into the airway, we have to bypass this area. And that can be true for any forms of swallowing difficulty, including radiation damage, not so much Zenker's diverticulum, but more commonly after a stroke. And we have to basically bypass this area because of the danger to the airway. And so one of the ways there are a couple ways to deal with that. One is you can put a tube through the nose called a nasogastric tube, nasogastric tube, which goes into the stomach, or more commonly what we call a nasoenteric tube, which goes into the small bowel. And this allows us to put nutrition and the water that you need through the tube directly into your stomach or your small bowel, thus allowing us to get nutrients in. That's more of a short-term fix. Usually that'll be more in a hospital type setting. And if you think that you're going to be, that the whole process is going to improve within a month or two, maybe 3 at the most, then you might consider that approach. But it's very uncomfortable because when a person's awake, having this tube in their nose is a problem and irritates the nasal passages, and it can also give you problems with your sinuses. And so that's more of a short-term solution. The second option is to place a feeding tube directly into the stomach. This is what's called a PEG, or percutaneous endoscopic gastrostomy. And basically we use an endoscope to go down and we put a hole in the stomach that ultimately leads to a tube being placed in the stomach wall. And so if you look at it from the inside, there's a little bumper on the inside. The tube comes through, and then there's another one on the outside to keep it in place. And that allows us to put material directly into the tube into the stomach. If the stomach is not emptying well, then sometimes we'll run that directly into the small bowel so that we can, again, keep the material away from the esophagus and potentially coming back down into the airway. So I forgot to mention that earlier, but that's an important tube. Sometimes we can't get a tube in place because a person's had surgery like a gastric bypass, or they've had ulcer disease, this kind of thing. And so the surgeon will have to put the tube in. And we can, of course, do the same thing in the small bowel, both by endoscope and also through a surgeon's help, usually through laparoscopy. So as we continue down the esophagus in terms of our causes of swallowing difficulty, the next level is this upper esophageal sphincter. And sometimes people can have a situation where there's scar tissue that develops here, or a person has what we call a cricopharyngeal bar, which is where the cricopharyngeus, the muscle we talked about earlier, this upper esophageal sphincter, just doesn't open well. And so when you go to swallow, the muscle does not relax properly and food will hang up. That can sometimes be treated by endoscopy with dilation of the esophagus, usually by what we call a Savory dilator, in which we put a wire in the stomach while you're asleep and during the procedure, bring it out over the tongue, and then run a tube over that called a bougie, which is shaped just like my pen here. It's got a narrow tip, flares out to the diameter that I want, and we just run it right over that wire and stretch everything out. So that stretches out this area. Sometimes that doesn't do the trick, and so you have to look at other options, such as surgery, which again is used in which they can actually divide the muscle. Just like in the Zenker's diverticulum, where usually that kind of repair is going to be surgical as well, and that diverticulum is open, so you can't, it won't hold the material or pill fragments any longer. So that's another thing that can cause it. As you come down the chest, you have things that can press from the outside. Like I said, your spine is in this area right here. You can get what are called osteophytes, which are bony growths. And if they come forward here and they impinge on the esophagus, then you can have a sensation of swallowing difficulty. You might even have a sense of fullness, what we call a globus, Globus sensation as well. And so that can have an impact. Then as you come down, like I said earlier, you have lymph nodes that line the esophagus. You have what's called the subclavian artery, which comes across kind of in this area right here. If it's going in the wrong direction, it can impinge on the esophagus. Some people, when their heart gets big, like if they have heart failure, for example, then the heart sits about in this area here, and so your left atrium, the left upper chamber, it rests against the esophagus, and it can create almost like a little speed bump there. And so that can also cause problems. Then, as you get more towards the lower esophagus, you start seeing acid-related complications. And these can include what we call a peptic, P-E-P-T-I-C, stricture, in which the acid reflux, as it occurs over a period of time, the acid gets into the inner layer of the esophagus, and it causes scar tissue to be laid down here. And scar tissue is not like a rope. It is a dynamic tissue. It has muscle elements in it. It has nerve elements. And over time, it actually contracts. It doesn't just stay in a static state. And so over time, as this opening closes down to about 12 millimeters or so, that's when food is going to start hanging up. And so initially, everybody gets a warning symptom. You'll get you will be eating steak at Texas Roadhouse or something like that, and it'll get stuck, and then you'll drink water, and it'll go down, and so you're like, oh, thank goodness it didn't stay. But over time, that's more and more things are going to get hung up. You're going to start modifying your eating, and at some point, the food can get stuck and not move, then you have to have one of us come in to actually either push that through or remove it by pulling it out over the tongue. And sometimes people will stack things. So in other words, they get a piece of meat stuck and they're like, well, that meat didn't go down. Let me put down a couple biscuits on top of that, maybe a Schonnerbach on top of that as well. And usually all that's futile, and then of course we have a lot more to deal with when we go in to take it out. But about 10% of people will develop these narrowings related to reflux. Some people come in and they have no symptoms of reflux, and they present with this instead. And so that's something that usually is more down the lower part of the esophagus, but you can see narrowings higher up as well. Again, related to radiation damage, for example. Also, you can get what are called esophageal webs, where there's like a little ring almost that develops. Sometimes we see that along with iron deficiency anemia. A real common, I think a fairly common problem that we see is what we call a Schatzky ring. And the Schatzky ring is due to acid reflux. And this is just a little ring of scar tissue that develops right at the junction of the esophagus and the stomach. And it's like if you took some saran wrap and just folded it on top of each other. It's a very thin ring. But that always occurs due to acid reflux. And so again, the symptom will be very similar in terms of the your swallowing difficulty. Again, mostly solid food. So that's a general characteristic of disorders of the lining of the esophagus, is that you usually will have problems with solid food, as compared to what I said earlier about the neurological problems, where it's mostly liquids. Another thing that you have to think about that we're seeing, that's actually a disease of modern times. The code for it was first described somewhere around 2008, but what we call eosinophilic esophagitis. And what happens in eosinophilic esophagitis is that you have this infiltration of a type of white cell called an eosinophil. And I may do a separate video on that. I haven't decided yet. But this is the stomach here. But the way your intestinal tract is set up is that you have these layers. So in other words, this is a cross-section view of the esophagus, and the tube would come here. And so what happens is you get this kind of a significant number of these eosinophils. And the eosinophil is a type of white cell that mediates allergies, and so it releases a lot of substances that help to recruit in other cells, but also that give you various things. So when you have eosinophils in your respiratory tree, then you have more problems with asthma-like symptoms. If you have it more in your sinuses, that kind of thing, then you're going to have drainage and all kinds of allergic type responses. So it's important in that kind of thing. And so there's been some discussion as to exactly what it is. We know that when you have acid reflux, that these eosinophils will be in the esophagus, but usually not at a really high concentration. And so when we take samples of the esophagus during endoscopy, the pathologist will tell us how many eosinophils you have per high power field. And so if that's over 50, I'd go by 20, I think over 20 is what you really need, but some authorities think it's 15 eosinophils per high power field. Then you have this eosinophilic esophagitis. And the way it usually will present, many people don't know, they don't have any kind of allergic type reactions or anything as far as rashes and that kind of thing like you get from drugs. But what they do is they cause inflammation, and just like everywhere else in the body, scar tissue lays down, and so people will come in with swallowing difficulty. And it also causes some esophageal spasm as well, so it might even give you chest pain that's not related to exertion, and symptoms that are a little bit more unusual. But anyway, so anyway, you go in and you look, and many times you'll see these little, like, just ring after ring after ring, that's or contraction almost, that it almost looks like your windpipe in a way. And so anyway, it responds well to doing endoscopy with dilation, just like the narrowings do. And then once we make that diagnosis, usually you get kind of a divergence as far as what the academic guys do versus private practice. It's very hard to get someone to go back and do another upper endoscopy, every 3 months to see if what you're doing makes a difference. And so the first thing that you want is you want to eliminate the possibility that acid reflux is causing symptoms. So a trial of a proton pump inhibitor is usually in order. And then after that, there's no specific FDA-approved therapy for this. And so what you'll end up using is some of the medicines used for asthma, the steroid medicines used for asthma. So one of those is called Flovent. And what you do is you'll get the person to take a couple puffs, not to inhale, but actually to swallow, and then you don't eat anything for an hour afterwards. And that actually is really effective. There's another one that's called budesonide that is known as Pulmicort, and that one you got to do a little bit differently. You have to do it through what's called a nebulizer. So I like to use Flovent. And so usually what you'll do then is you'll go a couple months, usually about 8 weeks of therapy, and then you'll stop it. And so with the academic guys, they want us to go back and look and take biopsies and prove that it's gotten better. And it's just kind of impractical with the cost of medical care and getting endoscopy at a facility, and you got to be put to sleep and all this, and do that often. It'll really strain your budget. But it's been shown that if you do the steroid trials, that you'll get usually about 8 or 9 months before retreatment is required. So that's actually pretty acceptable. And so that's something that it seems to be getting more and more common. We know that this eosinophilic esophagitis is related to a food allergy. Problem is that food allergy testing, like skin testing, for example, usually doesn't reveal what it is. And so there are a number of foods that have been identified, and it's so many things. It's almost crazy, but it's peanuts and shellfish and meat, and it's just broad categories that most people I don't think would tolerate eliminating food. And so I think most people prefer to get medical treatment for it rather than eliminate so many things from the diet. And then when you eliminate one thing, then you're supposed to go back and re-biopsy to see if that actually decreased the eosinophils. And again, it's just not practical right now to do that. But it is a food allergy without a doubt. Then you have situations in which you develop what we call a pill-induced esophagitis. And so a lot of people will take medications before they go to bed, and then they'll just lay right down. And so if that pill does not clear your esophagus, there's potential for it to dissolve on the surface of your esophagus, and that can lead to ulcer, irritation, and symptoms. And then ultimately you can get problems with narrowings. But when you get this, which is called a pill-induced esophagitis, typically you're doing fine, and then you wake up, like usually the next day, and you have chest pain when you swallow. You have swallowing difficulty, but it's actually painful to swallow, and so other medications can one of the kind of the classic one, the medications for osteoporosis. And back in the day, the medication Fosamax was given before bedtime. And so if that Fosamax did not clear the esophagus, it really tore it up. I mean, I still remember those days when I first started seeing that, and it was just amazing how much irritation there was. In some people, even if it went into the stomach, it would do that. It would cause an ulcer right here, and it'd be almost like a bomb went off with all the redness that radiated out from the ulcer. And so that medicine can do it. There are a number of other ones that you have to think about that are taken real commonly. Your non-steroidal anti-inflammatory drugs, again, can do that. If you can give you the pill-induced esophagitis. Vitamin C, potassium chloride, minocycline, maybe even the minocycline is a kind of a classic one. And then a number of other ones too, but those are the main ones. So again, when you go to swallow your medications, use plenty of water and don't lay down immediately, because I think there are other ones that almost certainly have this potential. So pill-induced esophagitis, most of the time all we have to do is do upper endoscopy, and we prove that the diagnosis is there. But many times it's very classic presentation because of you have no symptoms, all of a sudden you did something and you have subsequent symptoms. And if a person is doing okay, you generally don't need to do that. Obviously, little babies and children can get into chemicals around the house. The worst, of course, is to get into strong alkaline substances like lye, and so when those things make contact with the esophagus, really tear it up. And depending on the severity of that, you obviously end up with chest pain, swallowing difficult, painful swallowing. Then you have infections. These are not too common. In people who have a normal immune system, the most common infection is what we call herpes esophagitis, which is the same type of herpes that gives you cold sores. And we just don't see that too much. And people who have diabetes or they're getting cancer, chemotherapy, stuff like that. Then you see thrush or Candida. Many times that Candida will also be in the mouth, but not every time. And so if it's in the esophagus, again, you'll get painful swallowing difficulty, painful swallowing. You might have chest pain. And so those things also have to be considered. I mentioned radiation earlier. The main, with the infections, we're obviously looking for fever. Usually people are quite sick and they have a history that points us in that direction. Painful swallowing is not that common, actually. You have the infections as one cause, the pill-induced esophagitis is a second. Reflux usually doesn't do that, but severe reflux might. And so obviously symptoms like that, you need to make sure you visit with a practitioner and talk about it. That's serious. And of course then, before we move on, we need to talk about esophageal cancer. And so the classic esophageal cancer was the tobacco and alcohol related one, which was called squamous cell carcinoma. And so that one comes from the natural lining of your esophagus, and we see, in my practice, I just don't see that too much anymore. It's still out there, but it's not quite as common. The oncologists, radiation oncologists, and the medical oncologists have done a really marvelous job with that, because with chemotherapy and radiation, I've seen people do really, really well with that. But the one cancer that obviously is increasing in frequency that we're all paying a lot of attention to is what's called adenocarcinoma of the esophagus. And so again, you have these layers, and the adenocarcinoma as well as the squamous cell carcinoma come from this innermost layer. And so as the cancer is forming, it's a stiff area. It doesn't distend well. So you're going to get swallowing difficulty. Again, usually to solid food, just like you get with the narrowings related to reflux. So you have to get this evaluated. You cannot assume that that is just a benign narrowing that you can handle. By the time you start getting weight loss, throwing up blood, low blood count, this process is far along. One of the problems with the esophagus and the way it's designed, I just shouldn't say it's a problem, but it's just the way it is that most of the rest of the gut has it's like a wrapping. In fact, if you eat sausage, you've noticed that wrapping of a small bowel. But it's almost like this like a fibrous kind of wrapping around the esophagus around the GI tract. It's called a serosa. That is not present in the esophagus. You have what's called adventitious, so it's a looser tissue. Well, as the cancer forms, of course, it starts going through the deeper layers of the wall. And with esophageal cancer, it is usually advanced. It's usually not at a curable stage. I mean, most people who develop esophageal cancer are going to die from that cancer, and many times you can't even do surgery, and the surgery itself is really significant and has a lot of morbidity, meaning you have a hard time recovering, as well as mortality, meaning you could die from it. Most of the time, in my experience, the cancer is already out into lymph nodes, and it might have spread elsewhere as well. And so at that point, your options are limited, and you're looking at chemotherapy, radiation. Both those make you quite sick. If it's a real advanced situation, then we can burn the tumor. If it's there and you can't get it cured, we can burn it away with various techniques. And then sometimes we have to put in what's called an esophageal stent, which is usually an expandable metal stent that we run across the tumor, and it props it open. But when you get down here close to the connection between the esophagus and the stomach, it's a real problem, because you have free reflux after that. And so again, my main emphasis is just to say, make sure if you have swallowing difficulty, get it looked at. Very important. But again, usually endoscopy is going to be a big part of that. Evaluation, CAT scan. And then, and of course, what's called a PET scan, which tells us where the cancer may have spread to. But after that, it's the options are just not too hot. So, all these things we just talked about involve the surface, the narrowing, the pill-induced esophagitis, infectious esophagitis, reflux esophagitis, which we talked about in a previous video. And so, all these things have an impact on the inner surface. Most of those are going to present with swallowing difficulty to solid food. Then, as you move into the wall, again, this is stomach lining, but you have this kind of a similar thing. You've got a couple of layers of muscle here, and so these muscles can develop problems. And so one of the most important, and these are what we call motility disorders, and these are, again, present more with problems related to liquid and solids. Or you might have temperature sensitivity, hot liquids, cold liquids. But usually that's where the problem is. You might have chest pain as well because, again, it's more of a muscle problem. The main disorder in regarding the muscles is what's called achalasia. Okay, so we're gonna talk about achalasia, and I'm gonna bring you over to this the disorder chart to explain this. So, achalasia is a condition in which you have two main problems. One is that you've lost that stripping wave that we talked about earlier, where when food is above my pen, it contracts, and when it's below it, it relaxes and it pushes it down. So you've lost what's called peristalsis. The second problem with achalasia is that you have this lower esophageal sphincter here, and you have two main inputs here. One is through a chemical that's called nitric oxide, and that actually relaxes the lower esophagus. And then you have what's called acetylcholine, which is responsible for keeping it contracted. So these two, what are called neurotransmitters, are opposing each other, and they have different kinds of nerves. So what happens in achalasia is you lose the nerve network that's in the esophagus. In fact, more recent studies have shown that these nerve changes actually stem back into the brain in a nerve called the vagus nerve, which comes out of the lower part of your brain and powers the intestinal tract. And so you can go back to one of the main nerve cells that make up that generate this vagus nerve, and you can see some problems in that as well in autopsy series. And so there are a couple different types of achalasia. I'm not going to get into that with you. That's more for gastroenterologists. But depending on the type that you have, it can present in different ways. It can show itself on diagnostic studies in different ways. And so the problem that people develop is over time they get trouble swallowing both solids and liquids, may notice some temperature sensitivity. It can actually get to a point where when the esophagus is really not emptying well, you can actually regurgitate, and so and that can also occur in reflux. Okay, so you can have material come up, but when you have acid reflux, it's a sour taste. But when people regurgitate with achalasia, it's a bland type regurgitation. It might have food in it from before, but it's bland because the acid is not getting into the esophagus. It's what's already up in there. And so they might have that. They might regurgitate, and they might find volume coming up when they bend over, and this kind of thing. Also, they might have chest pain. Again, if you have a variety in which you have spasm of the esophagus, you have different sections just kind of contracting on their own. And so not only do you have the swallowing difficulty, but you might have chest pain, particularly early on. And so what happens in achalasia is that you go to swallow, the esophagus is just like a lead pipe. Things just kind of go down by gravity alone, and then they get down to the bottom here, and because you've lost the nerves that generate this nitric oxide, then the esophagus is contracted right here at this lower esophageal sphincter. So here you can see it, and so it comes down, and you get what's called a bird beak deformity, and that can be seen on X-ray, and that's kind of a classic appearance. And so again, the symptoms are swallowing difficulty, including the other things that I mentioned a few minutes ago. When we go to make a diagnosis of this, you have, I think, again, a little bit of divergence between academics and private practice. When I was at Johns Hopkins, when we had people who had swallowing difficulty, we would have this conference, and we'd have head and neck surgeons there, radiologists, even some surgeons sometimes, gastroenterologists, present the patient's situation. We do all these different types of evaluation, and then we would decide on what to do. In private practice, it's short. There's quite a bit of a shortcut in that regard. And so when I think someone might have this, if they're having trouble swallowing liquids, I think there may be a problem with, again, what's called esophageal motility, the way the muscles are working. I like to get a barium study first, because when I go to look at it with a scope, if it's a person with early achalasia, it may look, might look pretty normal. I can usually tell that you can tell there's some features that help you, but I like to see that. And so when you swallow the barium column will just sit right here, and then it'll have just a little bit that'll kind of peek into the kind of towards the stomach here, and it makes what I mentioned earlier, which is called a bird beak deformity. So that's a classic thing. Then the radiologist can also help us, because when the person initiates the swallow, if they don't see that wave of contraction coming down, that's also very suggestive. So many times that's the thing that we will pick up. Over time, the esophagus can dilate, and it can get almost like a corkscrew shape, or what we call a sigmoid esophagus, where it looks like the colon almost, because it's so dilated and turned. And so that obviously is an advanced stage, and it's not hard to pick up by any method. Endoscopy has an initial role, because many times people will come in having more trouble with solid food swallowing difficulty. And so we'll go in and we'll put the person to sleep, go down with a scope, and we'll dilate the normal way. We'll put a wire in, bring it out, and run a tube over. And so then I'll always say, if you don't get better within 2 or 3 weeks, you know better, let me know. And so that's usually when we'll do the barium swallow, and sometimes we'll pick it up after we've already attempted a dilation. The gold standard for diagnosing achalasia is what's called esophageal manometry. And like I said earlier, when you have esophageal manometry, a tube is put down the nose and into the stomach, and then it's pulled back into the esophagus while you're making swallows. And so we have pressure sensors on the device, and we can see waves of contraction running through there. We can also look at the pressure here in the lower esophageal sphincter. So if the pressure is high, and then when you initiate a swallow, it doesn't drop significantly and down to numbers that have been defined, then it's a good chance we have basically the diagnosis. But again, in private practice, I think we do a pretty good job diagnosing this using barium studies. Mainly because insurers don't want to pay for esophageal manometry, and so in practice, if a hospital can't cover its costs, they're not going to have the device, and we can't do the study. I think impedance plasmathography, we talked about that earlier, where you can take different kinds of measurements. That's sometimes employed in this, but and it's more to define the pressures that are being generated in the esophagus. And again, in private practice, I think that would be uncommon. One thing that you have to make sure of is that you don't have what we call pseudoachalasia or secondary achalasia. What we mean by that is that you've got this narrowing here, okay? And so when a person has swallowing difficulty, and let's say you do your barium swallow, you see this narrowing. Well, that narrowing could be due to a cancer. And if it's coming from the surface of the esophagus or the top part of the stomach, then we can see that with an endoscope. But if it's actually a cancer that's growing in from the outside, let's say like a lymphoma, a cancer of the immune system, or maybe a lung cancer that's spread into lymph nodes that are around this area, then it can be infiltrating from the outside, and so that's where a CAT scan would become useful, and also what's called endoscopic ultrasound, where we can actually go down with a scope that allows us to look through the wall, so we can see this growth coming in to the wall. So that's obviously something that would be more likely in a person as they get older. And so the treatment for this is, there are different ways you can go on this. You have your least invasive, which is to do what's called a botulinum toxin injection. And I was one of my professors at Johns Hopkins came up with this idea, and I was a fellow when he was we were doing study patients on this. But basically, it's real simple. You go down with a scope and you inject botulinum toxin into the muscle layer of the esophagus. And what that does is it temporarily paralyzes the lower esophageal sphincter, and it actually works fairly well. I've been pretty happy with it. It's not a permanent effect. It's just like when you get it for wrinkles or whatever else, you have to go back and do it. And so you'll get a good 6 months of relief, but it could extend up to 18 months. I think this is a better approach for older people, it is one in which, because it's so minimally invasive, you're not dealing with esophageal surgery, low risk of perforation. It's a good way to go. And so it's one of the things I offer. Some younger people don't want to get surgery any more than anybody else, and so we'll go that route if necessary. There was a new endoscopic approach which actually makes an incision into the wall, but not through it. and then you actually go down and you create like a little tunnel down into the lower esophagus, towards the lower esophagus, and then you go in and you actually, with a scope, make a cut in the muscle of the lower esophageal sphincter. And this is still experimental. It's done in some academic places, and it seems to work really well. And again, you get to do this without cutting through the abdomen and the risks that go with that. When you cut muscle in the human body, it does not heal back as muscle. It heals back as scar tissue. So when you've ruptured that circular muscle, it just can't close as tightly as it did. It's asymmetrical, and that allows a person to swallow. The only problem with that is that when you open this up, then you have the reflux that comes afterwards. And for some people, it's just intolerable, and they have to have a reflux procedure to fix that. So I'm not really crazy about that approach, although it's not bad. For a long time, we've had the ability to do esophageal, what's called a balloon dilation of this area. And the dilation that's done for this is with much bigger balloons than what we use for your typical acid-related narrowings. And so what you do is you go down with a scope and you basically put this balloon across the lower esophageal sphincter. With this, you're going to do that under X-ray guidance. And then you fill this balloon up, and what it does is it just physically ruptures the lower esophageal sphincter. The trick is to rupture the sphincter, but not rupture the esophageal wall. And so when I was trained on this years ago, the risk of perforation risk was about 6%. More recent literature claims that it's maybe down to maybe 1 to 2%. I don't know about that, but I know that's what it was for a long time. And I don't know that the technology hasn't changed to a point that it should have dropped it dramatically. But anyway, that's the current literature. And so it works really well. In fact, some studies suggest that it might be a better approach than surgery or comparable to surgery. The main problem, again, in my experience, has been that when you open this up, then you have free reflux coming up, and then you're committing the person to long-term, especially younger people, long-term antacid therapy. As we've talked about in the first reflux video, when you take medical therapy for reflux, you are not affecting this volume regurgitation. And so, again, I prefer an approach that the balloons are okay, but I like an approach where we fix the problem and we take care of the subsequent reflux that's likely to happen afterwards. And so I prefer what's called a laparoscopic Heller myotomy. And this is done by surgeons, obviously, and they do it the same way you get the gallbladder operation, in that they make small incisions along the rib cage and one at the belly button. And so what they do is they come from the outside and they do the same thing. They cut through this muscle layer, and then they do a fundoplication. They take the left side of the stomach and wrap it around to give you an anti-reflux procedure at the same time. And this is done laparoscopically. I like that surgery. I think I prefer. That's what I usually will refer a person for, is to get that done. So that's what I like to do, and it's a good approach. Some people will have ongoing symptoms because you still have messed up swallowing from the lack of peristalsis up here. Some people have chest pain. Then you kind of get into things like some of the old antidepressants, hypertension medications called calcium channel blockers have been looked at. And most of the time, unless a person already has hypertension, you run into so many side effects that stuff is just not that effective, in my opinion. But antispasmodic medications and a number of other things are important. Then you can have some other issues with the muscles of the esophagus. From what we used to call diffuse esophageal spasm, where you still have normal muscle contractions of the esophagus, and that they propel things from top to bottom, but you might have different segments that kind of contract at the same time, and that can give you swallowing difficulty. But usually that kind of thing will usually go away. We usually don't. You can use botulinum toxin for that. I don't usually do that. Again, the medications, some of these antidepressants, calcium channel blockers, they may help. Antispasmodics, those things are all considerations. It used to be a condition that we called nutcracker esophagus, where you had normal contractions, you had normal peristalsis, but the contractions were really powerful. They were much higher pressures than normal, and so people would get chest pain from that. And so again, those two, both the diffuse esophageal spasm and the nutcracker esophagus, are diagnosed primarily with the esophageal manometry. And most people, you can kind of, just by giving them the diagnosis, that's enough. Again, you go through the medical therapy I just talked about a minute ago. In some patients, if it's really bad, you can do what's called a long myotomy, where the surgeon basically just cuts the whole, most of the last 2/3 of the esophagus all the way down to again eliminate the contractions. I haven't seen that done in just a really long time. One of the things that we see in older people is what we call presbyosophagus, and it is a condition in which the contractions from above are normal, but the lower esophagus, the contractions can be incoordinated. So you might have contractions occurring here as food is coming down. You might even have contractions going backwards from the stomach up towards the esophagus. And again, it's one of those things we usually diagnose by barium swallow, and again, medical therapy is the primary mode of treatment. So these are all different conditions. There are a number of other ones. You have what's called Chagas disease, which is seen in South America. We don't really see that. I saw that one time when I was a resident in Houston. You have I talked about the compression from the outside. So the point is that there are a lot of different things. So don't make any assumptions about it. Obviously, the most disastrous thing to miss is a cancer of the esophagus, and it's just one of those things you need to get evaluated thoroughly. So in concluding, I think it's important that you realize that swallowing difficulty is not a symptom that you should leave ignored. It is an important symptom. As you can see, there are a whole lot of different things that can cause it. The pattern of the symptom is important, and you do not want to wait until you have a situation where you have something that's more of an annoyance, like food stuck in your esophagus, because that may be the sign that you have something very serious going on, particularly cancer of the esophagus. And so, as I mentioned, we have different ways that we evaluate things that range from the clinical history all the way to medical trials to radiography and then ultimately endoscopy. And then we have a variety of treatments. Endoscopy is going to be a big part of your evaluation and management, because esophageal dilation, which is done as part of the upper endoscopy procedure, is a very effective way to deal with a lot of these different problems. And it's usually the entry point that then branches off into other modes of evaluation. So again, the main thing is don't delay, don't deny that it's happening. Get it evaluated. That's the most important thing. So I hope that this video has been helpful to you. I deeply appreciate your time in viewing this. Whether you come to see me or you go to see another gastroenterologist, I hope that this will help you be a more effective consumer of healthcare. It will help you frame questions to your provider, and we look forward to seeing you on the next video. Hi, I'm Sean Panzer, and I'd just like to take a few minutes just to let you know about some of the different things that we offer through my office. Obviously, I'm a traditionally trained gastroenterologist from Baylor College of Medicine in Houston and Johns Hopkins up in Baltimore. But obviously, things change over time, and so I think it's important that a person also get kind of keep up with the times and be contemporary. And you also want to balance that with things that you know have worked from the past, because a lot of times things come up that are that seem to be awesome and something you want to put in your practice right away. But a lot of times you need the kind of the percolation of time to make sure that the procedure is truly safe and is one that's going to benefit a patient. And that does take a combination of experience and knowledge of the literature and other things. So I just want to make you aware of some other things that we do. Of course, you can obviously see me in the office, kind of the traditional way. But I also have telemedicine, which allows a person to have an office visit, a follow-up office visit over Google Duo or the iPhone FaceTime. And I can't do new patient visits that way, but it is covered by insurance and Medicare. And I use that a lot in people who have to drive or can't get here easily, or off in other places like in school, that kind of thing. We also have a nurse practitioner named Tony Perkins. She's sees patients while I'm here in the office, and her practice is mostly focused on helping people who need to be worked in that cannot be worked into my schedule, and so she's also available. We also do in-office hemorrhoid banding with a system called the CRH O'Regan system, and this is kind of the latest version of hemorrhoid banding. I've done hemorrhoid banding since I read about it, the endoscopic version in 1996, but this newest version is basically a painless version that does not require colon preparation. I can do it right here in my office, again covered by by Medicare and also by private insurance. We also have a type of radiology device that's called FibroScan. This allows us to quantitate, not only it uses an ultrasound technology which allows us to quantitate how much fat is in the liver, and it also allows us to tell liver stiffness, which correlates to how much scar tissue is in the liver. So if you have a chronic liver problem such as hepatitis C or fatty liver, then we can use this to, in a non-invasive way, to give us an idea of how much scar tissue you have. This may lead to a change in your management, either through medical management or to referral to a tertiary level medical center / liver institute for more for access to possibly clinical trials and other things. But in the past, the only way we could do that was with liver biopsy. You can also get similar information from an MRI, but MRIs are very expensive and it's very difficult to do a good MRI. The last thing I want to talk about is an alternative medication line that we're developing for digestive diseases. And the alternative medications are it's a big industry. There are a lot of people that carry the medications, drugstores, grocery stores, and all that. And there are just so many different products and so many different things out there, and it's just kind of mind-boggling, really. The unfortunate thing with a lot of those, for the vast majority of these supplements and minerals and herbs and these things, is that there's just no clinical data. So a doctor like me who prescribes your standard prescription medications, all of those had to go through scientific studies in which they were compared to placebo. They went through animal trials. They went through patient trials. And then a lot of times we have years of experience with these. And so we know that they work better than a placebo. But a lot of people are turned off by big pharma and the expense and just the suspicion that the medicines are not good for them, side effects, this kind of thing. When you turn to alternative medications, you have even a worse problem because you have so many different chemicals that are put into one product. You don't know which one works. You don't know which one may be interacting with medicines you're already on, that kind of thing. But people seek that care a lot and go to non-traditionally trained individuals and put a lot of trust into people that have not spent a lot of time either practicing medicine or studying medicine. And so what I'm trying to do over the last year is educate myself more about the things that are out there, try to get as much information as I can, scientific information, to help me make decisions as to what may work and what may not, and what does not work. And so that's what I've been trying to do is we're putting together a product line that will allow us to treat the things that we see. And so we're going to use these as a combination with the traditional medications, and hopefully we'll get better results as a result of that. These medicines will be available in the office. They're also going to be available online on eBay store as well. And so please give them a look. And obviously when you come to the office, I'll definitely describe those. But again, the idea is to get some kind of a product line that I can feel good about in terms of the production and also standardization, and where we can combine it in a controlled way as compared to just going out and taking a handful of different supplements that may be countering each other or just not doing anything for you and wasting your money. The last thing I'd like to talk to you about is hydrogen breath testing. This is technology which allows us to measure how much hydrogen you're exhaling. And Our bodies don't make hydrogen, only bacteria do. And so what this allows us to do is to look at, to see whether or not you are possibly malabsorbing different things, such as lactose and lactose intolerance, fructose intolerance, and also what's called SIBO, which is known as small intestinal bacterial overgrowth. This is a condition in which you have bacteria in your small bowel which should not be there, and in too high quantities, and as a result they are interfering with the function of the bile and also the digestive juice made by the pancreas and by your small bowel lining. When that happens, then you don't absorb things the way, digest and absorb things the way you're supposed to. They go lower in the bowel where they're broken down by bacteria, and that's fermentation, and that can lead to anything from gas and bloating all the way to diarrhea and even weight loss. So it's something that's part of our workup of symptoms like gas, diarrhea, and bloating. So we're, like I said, we have these available now. We're always looking to add things I think are going to be helpful. These things are covered by insurance, and with the exception of the supplements. And I hope you give these things a look. Thanks for your time.